in pursuit of health and wisdom. Sapio with Buck Joffrey.
Welcome back to Sapio with Buck Joffrey, and today we have back Rob Hamilton from Prestige Regenerative Medicine. Rob, thanks for joining me again, man.
Happy to be back, Buck. Thanks for having me back.
Yeah, and last time we spoke a little bit about men's hormonal replacement, which is actually kind of a pretty involved topic, and
Yeah,
something actually knew a little bit about. And this show, I'm gonna know a lot less about, so I'm gonna rely heavily on you.
sure.
Now, in terms of your office, as I understand it, you're more than half women to begin with, right? In terms of your patients.
Exactly true. And the last time we went through and counted, I think we had 55% women hormone replacement patients and 45% men. So definitely it's
Yeah,
more prevalent among women. And so we take care of a lot of them.
yeah. And I think the reason I bring that up is because I think sometimes, you people may be looking at this show saying, okay, so we got two guys here talking about women's hormone replacement. What do
Yeah,
they know? I mean, that is, it is what it is. I can't really change the fact that I'm a guy.
nor
And
can I.
you're yeah and you happen to be somebody who treats more women than even men, so I think I just wanted to make sure that people understand that we're giving that perspective is what the perspective actually is. So just like with men, I think maybe a good idea to do is to start with sort of an overview of some of the hormonal issues that women go throughout their life. I mean, and I think this is actually really helpful for men too, because again, a lot of the time we're around a lot of the women, so it's good to
We
know.
hope so. We hope so anyway.
Yeah, yeah,
So
yeah.
I think the interesting thing, Buck, and I've said it before, men tend to have a long, slow slide throughout our lives as our hormone levels decline. And what I tell my patients and what I've seen is women tend to almost fall off what I call the hormonal cliff. So, every woman and to a great extent, every man is familiar with the idea of menopause. That's when a woman stops having menstrual periods and her potential fertility comes to an end. But you've probably heard it referred to by sort of old time women as the change of life. And, that sounds
Hmm.
very ominous and dire. And in fact, I think most
Yeah.
women would tell you that it is not a pleasant time for most women. I mean, obviously, there are some
Uh-huh.
advantages to no longer having to deal with menstrual periods, but most women tend within a couple years to have a very substantial change in all kinds of things. I mean, menopause comes with, sort of famously the hot flashes and night sweats. They'll say, "Gosh, I'm waking up in the middle of the night, throwing my covers off, sweating and soaking my pajamas or whatever." Um, but a lot of other things come with it too, and things that we can actually treat and improve. And so we do. And I'm happy to go into more detail about what those are
Yeah.
if you want
Well,
me to
first of all, let's do
expound.
this. So when for most women, is there a what's a typical age that you're seeing in your practice, and maybe that's different from like the averages or whatever. But I'm curious if you could kind of get into that when
I'm,
women
I'm,
start having these changes.
yeah, no, I'm glad you asked about my practice because honestly, what's in the literature and what we see are almost two different things. I think what you and I were probably taught in medical school was, late 40s to 50s, women would start to go through menopause. What we see is late 30s, and by that sort of
Holy
37,
cow!
38,
Really?
39. Well, so it's not typically menopause at that age, but it's what we would call perimenopause.
Okay.
So perimenopause or premenopause would be the time when some of the hormonal changes that will presage menopause actually start. And then, of course, eventually menopause, which is the cessation of menstrual periods for a year, and there's some other hormonal definitions of it, will happen. So we see women all the way from kind of their late 30s to their mid 50s that are perimenopausal and or starting menopause. And usually we can help
I-
a lot of their symptoms.
Is that affected? Is that age affected by how early women actually begin having their periods?
We think so. And there are lots of studies, and as with anything in medicine, there's a lot of speculation and a lot of uh, thoughts as to what the cause is, and also it looks like there are changes. We've now seen multiple reports in the medical literature that young girls are starting menarche, which is the onset of menstrual periods, earlier at an earlier age than they did in years past, and we're also seeing menopause happening earlier. And then, there's genetic components to be sure. There are environmental components. There are components about, lifestyle, sort of epigenetic triggers, how one eats, how one drinks, what toxins one's exposed to, that sort of thing, stress levels. But yeah, typically the earlier a girl starts, the more likely she is to go through menopause earlier also.
So there was, I think there's been a lot of controversy in women's hormone replacement in terms of, the science, in terms of the decisions on if to treat, how to treat, that kind of thing. And I remember even when I think when my mother was going through that period of time, is a while ago, but maybe that was in the 90s, or maybe it was early 2000s, and she was getting a lot of mixed information, right? That maybe it was not safe, maybe it was not the right thing to do. And I think maybe you could go over that, because I think there's still a lot of remnants of that particular, um, you know, quote unquote controversy, although I don't think it's a controversy anymore. And what exactly happened there? Because I think I've heard some people describe that as one of the big mistakes that modern medicine has made as a disservice to women.
I agree. I agree. So essentially, what happened is, menopausal symptoms have been around for, well, as long as the human race, probably. And
Yeah.
medicine, what we do is we try to figure out a way to take care of them. And so a number of products, and I will call them pharmaceuticals or drugs, were developed in an effort to address menopausal symptoms in women. Probably the most commonly known one is a drug called Premarin, and another was a drug called Provera. So Premarin was multiple estrogen-like products, and I say estrogen-like because none of them is exactly the same as what we would call bioidentical estradiol, which is the hormone that human females, and by the way, a lot of female mammals produce, and males, it turns out. But one thing we found out was Premarin was used with great effect to treat a lot of ladies' perimenopausal symptoms. It was great for hot flashes and night sweats and moodiness and irritability and many of the things that come with menopause. But a large scale study was launched in the early 2000s to figure out, is there a problem with this? And it turned out that there is a problem. Although it seemed to help with symptoms, it seemed to decrease cardiovascular risk. The women that were on Premarin and this is a big study with multiple study arms, but basically the women on these artificial hormone drugs had a much higher risk of breast cancer. And so, as is the case in the media, the headlines screamed, hormone replacement causes cancer in women. And so, once you get something like that out there in the general public, it's really hard to turn it around because, most of the reporters writing those stories don't go into the nuances of the studies. They don't mention that these are drugs, not bioidentical hormones, et cetera. What we have found since in multiple smaller studies, now there's not a giant study like the Women's Health Initiative that pointed out the potential cancer risks of these pharmaceuticals, but bioidentical hormones, meaning the exact same hormone that a woman's body makes and therefore expects to see, are very safe to treat perimenopausal and menopausal symptoms and don't seem to have any associated cancer risk, but instead help decrease the risk of cardiovascular disease, which is the number one killer of people worldwide and certainly Americans, and generally improve quality of life in a huge way. So, uh, unfortunately, though, there's still that remnant out there about every third patient that walks in the door, every third woman that walks in the door for hormone replacement in our practices. Well, what about cancer? So we have to explain this whole scenario. We're not giving you the drugs that potentially cause cancer. We are giving you bioidentical hormones, which generally have a much higher safety record.
Do you have a sense of what it was exactly that was potentially causing the cancer? I mean, was in a traditional hormone replacement therapy, was it because it was an estrogen based type thing?
So, estrogen is what we call a proliferative hormone. It causes cells to grow. And in the case of women specifically, it causes cells in the breast to grow and change, and it causes cells in the endometrium or the lining of the uterus to grow and change. Now, obviously, it has other effects in every other cell in a female body, but Premarin, in particular, which is the most famous drug used for this, if you look it up, the generic name is conjugated equine estrogens. And so essentially, there are about 20 different estrogen compounds. They use the main backbone of estrogen, but they're derived from a horse. And so giving a woman this horse estrogen, if you will, caused unopposed growth of cells in the breast and the endometrium. And so, of course, the cancers that we saw as a result of the use of Premarin were typically either breast cancers or endometrial cancers. And part of
Just to
that
be
is
clear, though,
just
Rob, it's not the equine part. It's not the horse part. It was the fact that it was estrogen, right? I mean, I
correct.
don't see why it would make a difference there.
Right.
Is it? Yeah,
Well, it wasn't the bioidentical estradiol, and so the body didn't necessarily know how to shut that hormone off because it wasn't exactly the same hormone that the body expected to see. So normally a hormone works on some cells, and then that hormone is metabolized or broken down. There are mechanisms in the body to say, okay, you've had your estrogen stimulus for a certain amount of time or certain effect, and now we're going to metabolize or break down that hormone so it's no longer effective. Well, we didn't necessarily have the mechanisms to break down those particular estrogen-like compounds that happen to be derived from a horse. So you're right, it didn't matter whether it was from a horse or anything else, but that particular compound was not able to be broken down and metabolized, so it continued to stimulate those cells in the breast or the
hmm
endometrium, and therefore potentially led to cancer. And that's a simplistic uh,
in other words, like so, of a
explanation.
bioidentical or a human version of estrogen would have a much shorter half life too, or is that? I don't
It,
mean to get too into the weeds, but I'm
yeah.
trying to understand like why, why that would make a difference. At the end of the day, it's not like we treat with estradiol for the most part, even with bioidentical hormones now, right?
Well, we sort of do, and that's an aside. So to be clear, the estradiol that we talk about treating women with is in fact the same estradiol that's found in dogs and cats and monkeys and et cetera.
Right.
So it's a bioidentical compound. The downside of a bioidentical compound is it is found in nature, and therefore it cannot be patented by a pharmaceutical company, and therefore they don't really have a good way to recoup their investment doing the
Right.
research and marketing of it.
So it's a
So
downside to them.
it's a downside to them, correct?
Right. Right.
So it
Right.
behooves a pharmaceutical company, for example, to develop a unique compound. So what they did with Premarin was they developed a unique compound that had a lot of different estrogens that were not made by human females.
Okay.
And
Got it.
the human female's body didn't really know how to turn off the stimulation from those when the time came. So I hope that kind of makes sense.
That
I mean,
that clarifies it. Sorry, yeah, I didn't mean to
yeah,
belabor it, but I
no problem.
I yeah, I just want to try to understand a little bit. So, one of the things that you mentioned and why we kind of alluded to this before was that, a lot of people call this one of the great disservices to women of the century, and specifically, what are the benefits of hormone replacement therapy? You alluded to cardiovascular. Maybe
Sure.
go down that route in a little bit more detail with some of evidence and anything else that you can add.
Sure. So, the benefits of hormone replacement therapy, and again, whenever I say hormone replacement, I'm talking bioidentical. In women are multiple. There's short-term quality of life benefits, things like mood, energy, sleep, recovery from exercise, libido, mental clarity, and focus. You'd be amazed how often we hear about what people call foggy thinking that gets better with hormone replacement. Uh, Suppression of the what we call the vasomotor symptoms of menopause, what I mentioned before, the night sweats and the hot flashes. But there are also some significant long-term benefits. As soon as a woman's estrogen level declines or disappears, her rate of development of cardiovascular disease starts to parallel that of men's, because estrogen is cardioprotective. It helps the blood vessels maintain their flexibility. Um, Osteoporosis rates go up. It's hard to delineate, but at least from the preliminary data, it looks like a woman's cognitive abilities and potentially the risk for things like Alzheimer's disease decrease with the appropriate hormone replacement strategy. So, what I tell my patients is there are all these immediate quality of life benefits, and oh, by the way, they come back all the time and say, "You've changed my life," which is incredibly gratifying as a physician. But if you do this right, we can hopefully get you some additional health span, some additional time where the cardiovascular disease and osteoporosis and cognitive decline that seems to be part of the aging process is quite a bit slowed or maybe pushed back. So those are the big benefits for bioidentical hormone replacement in women.
What so when you replace in women, what's the ideal way of doing that? Are we talking about and we were talking about this a little bit earlier, where Premarin was primarily an estrogen-based therapy, a horse estrogen, maybe a mix of different kinds of estrogens. But so what's in your view, what's the ideal way of treating a woman now?
So, like a lot of things in medicine, there's probably 10 different ways, and most of them seem to work. Allow me to show you a very low tech kind of prop I prepared for this, if that's okay.
Yeah.
I don't know if you can see this here, my little chart.
Well, actually, if you want, Rob, what you can do is you can just scan it and send it to us, and
Sure,
then maybe
we can show it on the screen.
we can just kind of put it up, but you can just talk
Sure,
through it.
you
So let's
bet.
see your low
So,
tech drawing here.
this is a very, very simple treatment of a complicated subject, but it's an explanation I use all the time with my patients. And essentially, what happens as a woman ages is she starts to lose these three very important hormones. These are what we call the sex steroid hormones. And then I'll just start talking and maybe you put it up on the screen later. So, the three important sex steroid hormones in a woman are testosterone, progesterone, and estradiol. And typically, and it's not always the case, but in most cases, a woman's testosterone level declines or starts to decline before the progesterone level. The progesterone level then starts to decline, and then finally the estradiol level declines. When estradiol level goes essentially to zero, a woman stops having menstrual periods, starts having hot flashes and night sweats, and they say, "Oh gosh, I'm in menopause." But that decline of testosterone and progesterone in the years prior to menopause, to that cessation of the estradiol production, is what we call perimenopause. And that's why we see these women in their late 30s and early 40s coming in. They come in and they say, "I'm still having periods. Maybe they're not quite the same. They're less regular or whatnot, or some are heavy, some are light, etc. But gosh, I'm tired. I'm moody. I'm irritable. I don't sleep well. I've got no libido. I'm not thinking clearly. I'm stiff and sore when I wake up in the morning." And so the strategy we use in our practice that we've settled on, and many other physicians that do this, is replacing a woman's testosterone when it is clinically indicated, and progesterone first, and we'll do that oftentimes in premenopausal women. And then once a woman stops producing her own estradiol, that we typically call menopause, stops having periods, we will assess very carefully whether or not we should give her estradiol or not. And the reason we don't give all of our female patients estradiol is because it turns out a woman has an awful lot of testosterone in her body. Most of her life, she has much, much more testosterone than estradiol. And the body actually makes estradiol from testosterone. So if we get a woman's testosterone level to be approximately correct, her body will oftentimes make enough estradiol to sort of take the edge off all those perimenopausal or those menopausal symptoms, the night sweats and the hot flashes, without us needing to give estradiol. And then some women do still need a little additional estradiol. But so our strategy in our practice is typically to replace a woman's testosterone when indicated and progesterone, and then evaluate the estradiol. And we have a lot of patients who we've been very successful doing that with.
So you
And
kind of do it one by one. You're not like doing it, like a all one size fits all. You're just
yeah,
kind of looking at things and replacing things as they start to decline.
yeah,
Is there ideal numbers that you look at? And I know we talked a little bit about this with
sure.
in the testosterone replacement one. So just some ideas in terms that women might have when they're looking at these numbers, um, through the labs that they may have from their primary care physician. Like, what kinds of numbers are you shooting for in your practice, and why?
Sure. So, like men, women seem to do best with their testosterone in what we would call the top quartile of the range. So, the range, of course, is very dependent on what laboratory one uses. At Quest, which is the lab we use, a woman's testosterone, what we call a total testosterone, is typically 2 to 45. And so, when a woman is less than half of 45, so right around 23, they usually start feeling pretty bad. So they'll walk in the door, they'll say, I feel terrible. I've got all this stuff going on. I'm 40 years old. Is there anything you can do for me? And if we have her lab work back and it shows a testosterone level of less than 23, I would say in general, she's a good candidate to try testosterone replacement. The challenge is there's not broad consensus in the medical community that women actually benefit from testosterone. The FDA doesn't recognize that it's beneficial in women. So, despite the fact that I can measure testosterone in women, I can measure the level, I can see a change in quality of life as their testosterone decreases, and when I replace it, a lot of them feel better. It's still not broadly accepted by most physicians that women benefit from testosterone. But I will tell you that women embrace it because it is generally life changing, and in some cases, even more so than they feel it even more so than men.
Rob, do you think that your practice is atypical in terms of how hormone replacement is managed, nationally? Is there something else that's typically done differently, or do you feel like you're kind of, doing what most people are doing in terms of replacement?
Um, First of all, as much as I'd like to be have some superpower and the best practice in the world, I would say no. I think a lot of hormone replacement physicians follow a similar pathway and a protocol, and there's ample literature to back it up. I'm standing on the shoulders of others who essentially do this, and I can certainly name names, and I could recommend. Actually, I'd love to recommend a great book to women called "The Secret
Yeah.
Female Hormone," which is very much what we follow, or a lot of what our practice is based on. It's by a obstetrician gynecologist by the name of Dr. Maupin, Maupin, and we recommend that book to a lot of our patients. So no, I don't think I'm doing anything super unique here. Now, there is
Okay.
certainly a camp of hormone replacement physicians who do not embrace replacing testosterone for women, but I think the majority of them at this point have realized how important it is. And what we do a lot of hormone pellets replacement in our practice. And again, most women really like the testosterone pellets for replacement. And then we use oral progesterone, and that's a pretty common way of doing it. There's other ways to do it, but that's worked very well for us.
So you mean again, and just I know we talked a little bit about this in the male hormone replacement show, but
Yeah,
the pellets, they're actually kind of, you make a small incision, you put the pellets in, then couple of
yeah.
sutures and close it up.
Just actually just steri strips. We don't even suture it.
Yeah.
So and
Oh, okay. So they're tiny.
it's a great procedure for women because the pellets literally look like a grain of rice. And we individualize the
Hmm.
dose, so you might get 1.5 grains of rice or 3/4 of a grain of rice, but that's the
Yeah.
size that they are. So we make a very small incision, insert the pellet, close it with steri strips. They come back again in 3 months and generally tell us that we have changed their life and they want to do it again, and it works very
So,
well.
I mean, I would imagine that you probably get a lot of women who, when you say testosterone, they're like, whoa, 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 what are you
Yeah,
doing to me here?
right. They say,
Uh,
I don't want to grow a beard and and such.
right.
And you are correct.
So, do you get those? I mean, do you get some of those side effects? What kind of side effects do you see? And part of it is probably temporary while you're titrating, you're trying to get these
Yeah,
doses right,
yeah.
but what kinds of symptoms typically and that kind of thing do you see?
Sure. So most side effects, like most things in medicine, are dose dependent. So it's incumbent on us as the practitioner to get the dose right. So we tend to start low and go slow. That was a something I learned doing hormone replacement therapy. So we start at a lower dose and then we ramp it up over time if it's not sufficient. The most common side effects in women are increase in either facial hair or the pigmentation of the facial hair they already have. And by the way, as women age, some of their other hormonal systems change to make them grow more facial hair. Acne, and further down the line, we see things like clitoral enlargement and voice change. And I will say that as a practice, you're sort of here with the acne and the facial hair. You're way over here with the others. We tend to try to sneak up to the acne and the facial hair and back them down, back their dose down if they need it. Of course, if I mention
Yeah,
that to a woman, they say, "What? I don't want those." And I say, "Well, I've got 500 other women I'm taking care of, and not a single woman has come in and said I want to grow a goatee and have acne." So obviously,
right.
we are very careful with our
Yeah.
dosing to avoid that, and there are ways to treat that even if we
Yeah, and
overshoot.
it's obviously reversible too,
Oh,
right? I mean, if
yeah,
you basically come up to
yeah,
the line and you want to
yeah,
back off a little bit,
yeah.
um,
There's supplements, there's medications, but most importantly, we just reduce the dose, and we still
yeah,
get good
yeah,
effect at a lower dose
yeah.
most of the time.
What kinds of, you keep saying you change, you have these people, these women saying that you changed your life. Tell us a little bit more about that. Like, what kind of benefits are they seeing subjectively?
So, typically it's mood, energy, sleep, libido, and mental clarity. Those are the things that we hear about the most. Um, a lot of them report also a significant improvement in their ability to exercise. I've had some women who are very, fastidious about tracking their exercise output, these kind of athletes who are monitoring their energy output who tell me that their actual fitness goes up when they're on hormone replacement therapy. They'll measure the watts on their bike and things like that, which I thought was interesting. Most of our patients aren't doing that. Most of them just come in and say, "Gosh, I feel so much better. I am happier. I don't feel depressed and anxious like I used to." And I will add, the biggest market for antidepressants is probably in that peri or premenopausal woman. I mean,
Mm-hmm.
and
Interesting.
very few women are born with an antidepressant deficiency, but they do start to develop a hormone deficiency as they age. And I've had a number of patients who we've been able to have them stop their antidepressants. I certainly never tell them stop the antidepressants. I don't guarantee that, but many of them say I no longer feel like I need it. And I say, well, consult with your regular doctor, but if they want to stop it and see how you do. So, so a lot of things like that are very subjective, but very real to people.
Oh, again, we talked for men, we talked about some of the issues that with regard to sexual health
Sure,
and that kind of thing. And certainly there is analogous situations with women. I'm curious on, obviously when you're replacing hormones with women, some of these problems go away, but in many cases they may not. And
sure.
what kinds of things that you might be able to do for that?
Well, so I guess your listeners can be prepared for some anatomic detail here, if that's okay.
Oh yeah, no,
But
we can even put some graphs up and
not
of
not
some
not
images
not safe for
if you want.
work or whatever.
Yeah, right,
So
right, right.
I mean, like men, women have the same problem. As we age, our blood vessels are no longer as flexible, as responsive to nitric oxide signaling. They don't dilate, they don't contract and expand as well, et cetera. So, our first step with women who come in with any kind of sexual complaints is trying to make sure their hormonal milieu is appropriate. And a lot of women do, and you don't always. It's certainly not always their first complaint, but if you ask a few more questions, you find that they realize that they have very little interest in intimate contact. They have vaginal dryness. They don't achieve orgasm as easily. They don't find it as satisfying, and just and sort of it's a negative feedback cycle. If things don't feel good, you're less interested, and then it just becomes a chore.
Mm-hmm.
And certainly most people would rather that not be the case. So fixing the hormones oftentimes improves things like libido and vaginal lubrication, etc. But those aging blood vessels that comprise the clitoris and the perivaginal tissue, uh, much like causing erectile dysfunction in men, can cause a woman's sexual responsiveness to decrease. So I'm a huge fan essentially of something similar that we talked about in men, which is this acoustic wave or low intensity shock wave therapy for women. It sounds horrible with big electrodes and electrocuting people. That is not. It's like
Yeah.
a very
Yeah.
almost like an ultrasound probe, but it does wonders for regenerating the blood vessels. And actually, it's been fascinating to me. We've been doing it for about 2.5 years on women and probably 6 years on men. There's a lot more data in the medical literature on men that is published. There is now a fair amount of data published on women, but we've seen some real incredible wins. I mean, not only from a sexual health standpoint in women, from women coming in and saying things like, well, I haven't had an orgasm in 10 years and now I do, or I'm really happy. And oh, by the way, my husband's really happy and it's working great. But we've had women come in and say, my urinary incontinence has improved. And by the way, stress urinary incontinence is a huge issue in women. It's not usually talked about, and most of us men never hear about it. But it's a huge issue in women. Take it from me, having talked to a lot of patients about it. We've even had a couple patients tell us that other chronic conditions like chronic pelvic pain and things like that have improved, things like interstitial cystitis. So it's a tremendous technique for women, and we've been very
What is that called?
happy to use that. The brand name is FemiWave, FEMIWAVE. That's essentially just a technique for using a general medical device that creates, tissue shock waves or pressure waves for feminine sexual health. But
And so what does a typical treatment look like, and how often, and is this, how common is this, and that kind of thing?
sure. So we do a fair number of them, and obviously a big part of it is we have people that we've obviously trust us with those kind of things, and we have some people in our office that are just fantastic and talk to all of our female patients about it. But typically we'll do 4 treatments that last about 20 to 30 minutes each. It's done by one of our female technicians. They don't hurt. It's non-surgical. There's no scalpel or cutting. It's almost like just using almost like an ultrasound wand over the woman's genitals. And They go home and they feel fine. And over the next 4 to 6 weeks, things improve considerably in terms of all the things we talked about.
So
We
it's a single
oftentimes,
treatment, Rob? Is it a single
usually,
treatment?
no, usually we find 4 to 6 is the sweet spot where they start to get the
Like
most
once a
benefit.
week?
Once a week,
Once a
correct.
week.
Once a
Okay,
week,
okay.
20
Got
to
it.
30
Got it.
minutes. And then sometimes, Buck, I'll just add we combine it with injections of platelet rich plasma. I don't know if your listeners, excuse me, are familiar with that, but that's also a tremendous technique for improving both women and men's sexual health and a whole bunch of other cool things in the body. Is the use of
Yeah.
PRP. In the case of women, it's called the O shot, and there's information on the internet about that also.
Got it. Got it. What am I missing, if anything? What would be useful for us to add to this discussion?
I would say that if any ladies are listening to this, or any men who have ladies in their lives who are important and they're in that age group, sort of 40 to 55, and are not feeling quite as good as they used to and wondering why, they should absolutely get hormone levels tested and consider bioidentical hormone replacement. I mean, I think just
And I
to
guess the
raise
big thing is
awareness
don't
is
be
huge.
afraid, right? Don't be afraid of this situation, because I think
Exactly.
net what we're finding in the literature is you're better off doing this than not doing this.
Yeah,
And you're going to feel
absolutely.
better. You're going to probably live longer and all those things.
Absolutely. I mean, like you and I have discussed, live longer is a really hard one to pin down, but longer health span, absolutely, 100% for sure. And
Right.
I'm just continuously amazed at how big a difference these little tiny doses of hormones can make in people's lives. So it's
Yeah.
really worth looking at, and the risks are very manageable, and for the most part, very low to start with and very manageable. So, and just one other thing I'll throw in there: there is a lot of data on using testosterone replacement in women who either currently have or have had breast cancer. So we see
Oh, is
an
that right?
awful lot of women come in and say, well, my doctor said I can't have hormone replacement because I had breast cancer or I have a lump in my breast, et cetera. But there is a lot of data. A lot of it comes from a surgeon in Ohio by the name of Rebecca Glazer, who's published extensively on this. And testosterone replacement in those women can really be tremendously helpful also. So for the ladies who've had some scare with cancer, it's not necessarily out of the question. You just have to find somebody who knows how to deal with it.
Dr. Rob Hamilton. Thanks, Rob. I really appreciate your time. And how can we learn more about you and your practice?
My pleasure. And our website is www.prestigerem for regenerativemedicine.com. Thanks again, Buck. I really appreciate the opportunity to
Yeah, I
help
would love to have
educate
you back
people.
again sometime, man. Okay.
Absolutely. My pleasure.
All
Take
right.
care.
That's it for this episode of Sapio with Buck Joffrey. Hopefully you enjoyed. See you next time.